Good afternoon, everyone. My name is Ann Wong with the Illinois Chapter American Academy of Pediatrics, and I thank you for joining us for today's webinar for National Infant Immunization Week. Today we are joined by Dr. Mark Sawyer from the Rady Children's Hospital in San Diego and UCSD School of Medicine. Before we begin, I would like to go over a few housekeeping items. Participant phone lines are muted. This webinar is being recorded. Everyone will receive a copy of the PowerPoint slides, a link to complete the evaluation, and a link to the recording of the webinar by the end of business day. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel for the webinar located on the right-hand side of your screen. Your questions will be answered at the end of the presentation. I would now like to introduce Dr. Sawyer. Dr. Sawyer is a professor of clinical pediatrics and a pediatric infectious disease specialist at the UCSD School of Medicine and Rady Children's Hospital, San Diego. He is the medical director of UCSD San Diego Immunization Partnership, a contract with the San Diego County Agency for Health and Human Services to improve immunization delivery in San Diego. He is a current member of the American Academy of Pediatrics Committee on Infectious Diseases and the FDA Vaccines and Related Biological Products Advisory Committee. He is a past member of the CDC Advisory Committee on Immunization Practices, also known commonly as the ACIP. Dr. Sawyer has engaged in projects in San Diego and California to increase communication with the community on the subjects of vaccine hesitancy and to develop a curriculum for primary care residents to teach elements of vaccine safety and vaccine safety communication. His 3 children are fully immunized. Please join me in welcoming Dr. Sawyer. Okay, Dr. Sawyer, I'm going to go ahead and switch it over to you now.
Okay, good morning. Thanks very much, Ann, for the introduction. And Ann, if you let me know if the screen is showing the way you would like.
Yes, it looks perfect.
Excellent. Well, it's great to join you all today in celebration of National Infant Immunization Week. And Ann asked me, as part of that, to go give you a quick update on what's changed with immunizations in the last year. And a number of interesting things are happening. Some of them are with regard to vaccines that are only recommended for adults at this point in time, but I am going to touch on those because I think those vaccines, or at least some of those vaccines, will eventually be used in pediatrics as well. So my disclosures, I have no financial disclosures related to the presentation, and Ann already let you know my other disclosure, which is my 3 children are fully immunized. Here's a quick summary of the new stuff that's happened in the last year. And the most important thing I think that I'm going to spend a fair amount of time talking about is the reintroduction of the live attenuated influenza vaccine, FluMist, the nasal flu vaccine. The CDC has reinstated it as an option for influenza vaccine. And I'm going to go through the data that led to that change in recommendation and also share with you the opinion of the Committee on Infectious Diseases of the AAP, which I'm a member of, and we had a recent meeting in which we discussed the same data, and I'll share with you the AAP's position on this. Second change just recently at the most recent ACIP meeting was a slight change in recommendations for hepatitis A vaccine for infants under a year of age. Those infants who are traveling abroad to countries where hepatitis A is prevalent and therefore the vaccine is recommended as pre-exposure prior to travel. The age group for use of that vaccine in that setting is dropped down to 6 months of age, and I'll talk briefly about that. There are new vaccines there are no new vaccines for pediatrics, but there is a new adjuvanted hepatitis B vaccine that was just licensed and recommended for adults. It has the advantage of being only a 2-dose vaccine instead of 3, and I'll share some data about that just so you're up to date. And then more for you than for your patients, there's an adjuvanted zoster vaccine, which has also been introduced in the last year and is now recommended for all adults 50 years of age and older. And last new development was just presented at the ACIP meeting in February, which is new data which shows, in contrast to what we have been saying for the last couple of years, that college students are actually at increased risk for meningococcal B infection compared to adolescents or young adults of the same age who are not in college. This is in contrast to the ACWY strains of meningococcus, for which we already knew that, but up until now we've been saying B, for some reason, was not increased prevalence or incidence in college students, and there's new data to show that it is. So all of that really translates to is that sending kids off to college is one of the considerations that you could, one of the issues you could consider in deciding whether to use the meningococcal B vaccine or not. So that's a quick overview, and I'm going to go now into some more specifics with these objectives in mind, that at the end of this webinar you're going to be able to discuss the evidence that led to the return of LAIV for the upcoming season so that you can decide whether you're going to use it or not. Describe the travel-associated recommendations for hepatitis A vaccine in infants that I referred to. Something that's not new, and I may have covered in a previous webinar with this group, but I want to make sure everyone is up to date on being able to explain why the birth dose of hepatitis B is now supposed to be given within 24 hours of birth for all babies. So we're no longer supposed to defer hepatitis B to the first office visit. It's all supposed to happen in the first 24 hours. And then I am going to share with you some information about the new hepatitis B and the new zoster vaccines, because I think they're a vision towards the future of all vaccines, that is the use of adjuvants to enhance the immune response of vaccines. That is a characteristic of both of these new vaccines. And I think we will see some more pediatric vaccines developed in the near future that use adjuvants. And then a reminder that we still are facing a problem with pertussis, in part due to the short duration of protection of current pertussis vaccination. And we need to continue to strongly advocate for pregnancy Tdap immunization so that we protect infants who are the most vulnerable. So I thought I would start off just reminding all of us why we're in the business of giving immunizations. This is a recent set of data that just illustrates it quite dramatically. This shows the incidence of invasive pneumococcal disease in the United States over a relatively short period of time, from 1998 to 2016. And if you just focus on the gray bars in the graph, those are invasive cases of pneumococcal disease in young children caused by just the 13 serotypes that are in PCV13. And as you can see, we've had a dramatic decrease in invasive cases of those strains of pneumococcus, and it's just a graphical illustration of how effective vaccinations can be. In fact, there's even secondary benefits to reduction of PCV disease in children. That is, the incidence of the same 13 serotypes in adults 65 and over has gone down because we're immunizing children, not just because we're immunizing adults. So there's secondary benefit from vaccination as well. I found this quote online as I prepared this talk, and many of you will have no idea who Lennox Lewis is, but he was a boxer. And he said this relatively profound statement that sometimes success needs interruption to regain focus and shake off complacency. I assume that means he lost a fight and then tried to recover. But in the case of vaccines, I want to remind you that we cannot afford to become complacent. Measles, for example, as illustrated in this slide, is continuing to circulate. There are continuous outbreaks, particularly in Europe, that are reintroduced back to the United States as travelers go back and forth, and you can see the number of cases that have been identified in the United States over the last decade or so, and it's poised to cause future outbreaks because of the pockets of under-immunization that we have in our country. And the same thing is true for mumps, as illustrated here. We have continuing outbreaks of mumps, particularly on college campuses, but in other settings as well. So we can't really become complacent about vaccines. So let me jump to influenza, something that we never become complacent about because it changes every year. This is a diagram from the CDC of this year's current influenza season, which is just winding down. In fact, today my local health department declared the influenza season over for the purposes of healthcare workers wearing a mask, for example. We are still seeing cases, but they are way down here as they are across the country and shown on this graph. A couple of other messages in this graph. Excuse me. First of all, this was predominantly an influenza A H3N2 season. That's shown in the red. And that will be important to you as we talk about the nasal flu vaccine, because one of the problems with the data about reintroducing the nasal flu vaccine is we haven't been able to directly measure the effectiveness of the new formulations of vaccine because there hasn't been enough H1N1 disease in the community to do the effectiveness studies. The other lesson in this graph is the late resurgence of influenza B, which is shown in the green bars, and we've seen this over the last several seasons. I've not heard an explanation for why influenza B seems to come later and sort of finish off the influenza season, but it's important to keep in mind because even though influenza A may have peaked in your community, influenza B may not. And influenza B can be very serious for children. There are deaths every year from influenza B, just as there are from influenza A. And here's just another graph from CDC comparing this year's season to the last several seasons. And as you can see here, this was the biggest season we have had in the United States since the pandemic year of 2009 and 10, which is the faint gray or silver line off to the left. Reflecting the fact that it not only was a big year, but it occurred at a different time of year than is typical. So this year's season was typical in terms of its timing, but it was a much larger outbreak, and there were more hospitalizations, and there were more pediatric deaths this year than we've seen in recent years. Part of the reason for that is reflected in the influenza vaccine effectiveness. These are the mid-season estimates from CDC, showing an overall effectiveness of this year's influenza vaccine of only 36%. As is typically the case, it's less effective against H3N2 than H1N1 and less effective compared to influenza B. There will be an update of these figures that usually comes out about June, but clearly this was not a great year for the influenza vaccine. And by comparison, here's the overall effectiveness of influenza vaccines over the last 10 to 15 years. And it varies quite a bit, as you're all quite familiar, but this year's estimate puts it sort of on the lower half of where we've been over the last decade. So we clearly can stand to have an improved influenza vaccine. There's lots of work going into so-called universal influenza vaccines that will not have to be reformulated every year, but those are still several years down the road. So this slide presents our challenge in pediatrics. So this is pediatric coverage rates for influenza in the United States over the last 5 or 6 years. And as you can see, we're sort of plateaued. We're making slow improvements in coverage rate, but for example, the coverage rate in 6-month to 4-year-olds is pretty flat now over the last 4 seasons, with us immunizing around 70% of our younger children. So that means, of course, 30% are not getting immunized, and among the pediatric deaths that are reported every year in the United States, almost all of those children are unimmunized. And so we still have work to do. We have even more work to do in the adolescent population, as we're under 50% for influenza vaccine coverage. Next year, so it's tough to make predictions, especially about the future. This is what's happening with next year's influenza vaccine. There are two new strains, so the H3N2 strain is going to change, and one of the two influenza B strains is going to change. The H1N1 and the other B are going to stay the same. So as is often the case, this is a totally different vaccine, and that's why everybody will need to get re-immunized in the coming season. Okay, now I want to shift to talk specifically about LAIB, which for the last 2 seasons has not been recommended for routine use in children. And in fact, here's the statement from the MMWR explaining that in having to do primarily with concerns about low effectiveness against the H1N1 strains of influenza for 3 seasons in a row, the ACIP and the AAP recommended that LAIB should not be used. So that's been the recommendation that we've been working under for the last 2 years. And this is a quick summary of the data that shows why that's the case. So each of these panels represents a different strain. The left-hand panel is any influenza, but then the second panel is H1N1, the next one H3N2, and on the far right, influenza B. This data that I'm showing in this slide are the adjusted effectiveness for the injectable vaccine. And in contrast, this next slide shows you the same effectiveness numbers for the live attenuated vaccine over 3 different seasons outlined here. So let me just flip back and forth between these 2 slides, and you should focus, first of all, focus on the H1N1 column. So here's H1N1 effectiveness for the injectable vaccine, and here's H1N1 effectiveness for the nasal vaccine. Now I want you to focus on the influenza B column on the right. Here's effectiveness of the injectable vaccine, and here's the nasal vaccine. So it's pretty clear from these data that the nasal vaccine is inferior to the injectable vaccine for H1N1, and you might argue that it's better for influenza B, and this is part of the dilemma we have in deciding whether to use use LAIB or not. Is for some strains it may actually be better, but for other strains it's clearly inferior. So that's the data that led to the recommendation. And so now I want to share with you what's new that led the ACIP to recommend that we again start using LAIB. So LAIB is back, at least based on the ACIP recommendations. And this is the data that was presented to ACIP and to the AAP that led to this change. The 3 colored bars represent different strains of LAIB. The first 2 are a strain that was from the time period when the vaccine was not working well. So that's A. Bolivia, the 2 blue lines. And then a new strain that the company has determined is replicating better in the nasopharynx, and therefore they feel is going to work effectively, and that is the A. Slovenia strain, which is shown in the green bar. And the company feels like they have now solved the problem with the LAIB, and the basic problem was that the vaccine strains during the seasons when it was not working well were not replicating well. This is a live vaccine. It has to replicate in the nasopharynx in order to induce an immune response. So what you can see in this graph is shedding of the virus, which is an indication that it's replicated in the nasopharynx. And if you just focus on day 4 and day 5, you see that the new strain is shedding more than the strains that were not working. So this is indirect evidence that the vaccine is replicating, and the hope is then that it's going to induce a better immune response. And this slide shows that. This is antibody seroconversion after either 1 or 2 doses of the same 3 strains. The 2 blue lines are Bolivia strains, which are, again, from the season when the vaccine was not working, compared to the new strain, which was not used in the United States, but was used in other countries and was used in this clinical trial. And as you can see, the new strain does induce a better antibody response. Now, the caveats are that the sample size for this study is quite small. This is less than 100 children, and it is only children between 2 and 4 years of age. The last data slide that was shared is this one, which compares the vaccine effectiveness of the new strain, which is shown in the light purple, and then compared to a totally different strain called A. Caledonia on the right, which was a strain that was taken from a time way back prior to 2009 when the live attenuated vaccine worked very well. So again, you're comparing the left-hand column, which is the new Slovenia strain of LAIV, the better replicating strain. You're comparing those numbers to the panel on the right, which are a set of studies that using the very old strain of LAIV that worked very well. So to summarize, we have data that the new strain replicates better in the nasopharynx. We have data that the new strain induces better antibody than the strains that didn't work. And we have a little bit of evidence that the level of antibody generated from the new strain is similar to what the levels of antibody that were generated by the strains when the vaccine used to work. So that's the full extent of the data that's been presented and reviewed by any of the groups. And there are some concerns about that data. The gold standard for determining how well a vaccine, an influenza vaccine works, is vaccine effectiveness. That is, does it really prevent disease? So antibody levels are an indirect comparison, and viral shedding is not something that we really have used to determine whether the vaccine is going to work or not. So the biggest concern about this data and the reinstatement of the LAIV is we do not have any vaccine effectiveness data yet to show whether it really is going to work. We have indirect data that shows that it induces better antibody, but we don't have direct data that it's going to work. So when all of that was discussed at the AAP Committee on Infectious Disease at our spring meeting just last month, we had significant concerns about that. And this slide summarizes sort of the overall feeling of the Committee on Infectious Disease, and that is that the effectiveness of the new LAIV formulation for the coming season is unknown, and that AAP would prefer the use of the injectable vaccine because we know that that effectiveness has been established, and because of concerns that we're not sure that the new LAIV is going to work, particularly against H1N1 strains. Now, for children who can otherwise not be immunized unless you use the nasal vaccine, which would be children who refuse the injection or parents who refuse the injection on behalf of their children, or in settings such as schools where it's only practical to use the nasal vaccine, then it's certainly acceptable to use the live attenuated vaccine, and certainly it's better than no vaccine at all. So this is the conclusion of the Committee on Infectious Disease. This has not yet been made official, which means reviewed by the board of AAP, and neither has the ACIP recommendation been made official, which is when it gets published. So you need to stay tuned on this topic, but to summarize, the AAP is taking a slightly more conservative approach than the CDC and recommending that when possible, you should use the injectable vaccine. And I'll be happy to take questions on that topic. It's important for you to be aware of this difference of opinion as you decide whether to order and plan to use the nasal vaccine in the coming season. Okay, I'm going to shift gears and talk about hepatitis. Doesn't seem like much can be new with hepatitis, but here is a couple of worldwide maps that shows the ongoing prevalence of hepatitis A and B, A on the left, B on the right, just to illustrate the point that both of those viral infections are very common around the world. Hepatitis A is important to us primarily with regard to travelers who go to those countries highlighted in the dark red color where hepatitis A is still endemic. And hepatitis B is important to us as immigrants who come from countries where hepatitis B is common have an increased rate of hepatitis B and chronic carriage of hepatitis B, and we need to interrupt that transmission from pregnant women to their newborn babies. So hepatitis A, this is the new recommendation I referred to. Hepatitis A is now recommended for infants 6 to 11 months of age who are going to be traveling to those countries where Hep A is in high prevalence. And the rationale for that is those same babies under a year of age also frequently need or usually need MMR vaccine when they're traveling to those same countries. We used to use immune globulin to protect infants from Hep A when they travel, but that immune globulin interferes with MMR vaccines. So as measles has become a bigger problem and these ongoing outbreaks in other countries have led to reintroduction of measles in the United States, we've become more aggressive about immunizing babies who are traveling with MMR vaccine. And so we were unable to use the immune globulin and the measles vaccine simultaneously. So in order to protect against hepatitis A, the recommendation now is to switch from using immune globulin to using vaccine instead, and the vaccine works fine in conjunction with MMR vaccine. For post-exposure prophylaxis, hepatitis A has been used for a number of years in infants starting at 12 months of age, and of course that's the age at which we routinely immunize. And then another change for Hep A, not relevant to pediatrics, is that it's adults 40 years of age and older are now also recommended to receive hepatitis A vaccine rather than immune globulin. So that's a quick overview of hepatitis A, and this table just summarizes the various age groups at which you would use immune globulin versus vaccine for either post-exposure prophylaxis or for people who are going to travel. So for infants under 6 months of age, we are still using immune globulin, but between 6 and 11 months of age for travel, we are now shifting to use vaccine, and then the other age groups and adult uses are down below on that graph. Okay, hepatitis B now. I want to remind everybody why this is such an issue for us as pediatricians. And the reason is that chronic hepatitis B occurs in about 90% of infants if they're infected at birth or in infancy, 90% go on to have chronic infection. And this is in contrast to even slightly older children and children above 5, where the progression to chronic infection actually becomes quite rare. But in infants, it's almost guaranteed that if you're infected as an infant, you're going to end up with chronic infection. And that comes with the risk of premature death from cirrhosis and hepatocellular carcinoma. Again, much more common if you're infected in childhood than if you're infected as an adult. So the onus is on us as pediatricians to prevent hepatitis B in infants, and of course the way we do that is with vaccine. This was the old so-called permissive language for use of hepatitis B vaccine that said on case-by-case basis, first dose can be delayed after hospital discharge, and the physician can give it at the first visit. That is no longer the case. That recommendation has been changed, and now all babies are supposed to get a birth dose of hepatitis B within the first 24 hours of birth, with the exception of infants less than 2,000 grams. The rationale for this is basically the fact that mistakes get made in healthcare. That is, identifying women who are chronic carriers and whose babies really have the highest priority for getting vaccination and hepatitis B immune globulin. that system breaks down from time to time, and it's known that mothers with unknown or discrepant hepatitis B status are less likely to get immunized than babies whose mothers have clear status. And some of those women with unknown status turn out to be chronic carriers, and if their babies don't get immunized at birth, they're going to be in this group who are at risk to get chronic infection. This was sort of brought forward way back in the late 1990s when we briefly delayed the use of hepatitis B vaccine, except in the very high risk. And babies who should have been immunized ended up not getting immunized because of errors in record keeping or just lack of information. And they fell through the cracks and ended up with chronic infection. So to close those cracks that babies are falling through, the CDC has changed the recommendation, and now we're just supposed to give everybody a birth dose within 24 hours. The other change that came, it's been about a year now, so you may already be familiar with it, is the response to infants who don't develop antibody after the 3 doses. So for babies who are at high risk, in other words, being born to chronic carrier mothers, they are supposed to be checked after vaccination to make sure they responded, and if they don't, they need to get revaccinated. We used to always use a 3-dose regimen to revaccinate them, and that's shown up on the top line here in this diagram. We would give 3 additional doses and then recheck antibody to see if they responded. If they did, then they were protected. If they didn't, they were still a non-responder, at which point we didn't have anything else to offer except to be aware that they'd never responded to vaccine and therefore were at ongoing risk for infection. That has now changed. There's an option to use the bottom strategy on this diagram, strategy 2, which after 3 doses, if you check antibody level and the baby has not responded, you can just give a single additional dose and then recheck antibody. And in fact, the majority of infants will respond to that single extra dose. So if after that single dose they now have sufficient antibody, then they are considered protected and you don't need to do anything else. If they don't respond, then you give the additional 2 doses and do the same thing that we used to do. So that's a change in the last year, which just makes it a little bit easier for this small subset of infants who don't respond to vaccination. All right, now I'm going to switch gears and talk about the new adult vaccines. Because again, I think the future of vaccination in general, first of all, is going to be an increased focus on adults, but also the use of more and more adjuvanted vaccines. So let me tell you about the adjuvanted hepatitis B vaccine. This was just licensed by the FDA in November of 2017 and just newly recommended by ACIP. In fact, I think the publication in MMWR for the recommendation just came out this week. So this new vaccine is called Heplisav-B, that's the brand name. Its characteristics are it's a 2-dose regimen, which is going to improve compliance and ability to get people immunized quickly. It increases seroconversion in adults, particularly high-risk adults who are older but still at risk for hepatitis B, who have not responded as well to the old vaccine. And this vaccine for adults, can be interchanged with the existing vaccine. So again, this is not recommended for pediatric patients at this point. It may be in the future, but it is recommended for adults as an option to give. And this sort of illustrates why there was the need that feeling that we needed to improve our hepatitis B vaccine choices for adults. This shows the rate of acute hepatitis B by age group. So on the very bottom are children 0 to 19 years of age. It's become a very rare infection in children in the United States because of vaccination. But look at those rates for older adults. There is still significant numbers of cases every year of hepatitis B in different risk populations in the United States, including adults who have diabetes, which is a newly identified risk factor for developing hepatitis B, having to do with the sharing of blood glucose testing equipment in various settings that has led to several outbreaks of hepatitis B. The limitations of the current vaccine, we all know that giving 3 doses of any vaccine is a challenge, and it takes 6 months to complete the series for hepatitis B. But in addition, for the adults that I've mentioned, diabetics, for example, the response to the current vaccines was low, particularly in increasing as age increased, or with underlying conditions such as renal disease. So only 77% of hemodialysis patients respond to the existing vaccines. And there are other age groups there that show other risk groups that show reduced response to the vaccine. And that is in contrast to this new vaccine, which basically uses the same antigen, the hepatitis B surface antigen that's in all the other vaccines, but it combines it with an adjuvant, which happens to stimulate toll-like receptor 9, which is an important mediator of immune response in your lymphocytes, and is an example of sort of this new wave of adjuvants that are being explored for lots of different vaccines. It's a 2-dose regimen, and the 2 doses are only spaced apart by 1 month. So this allows you to get somebody protected against hepatitis B in a much shorter length of time and with only 2 doses. And here's the data about the improved immune response. So this compares the Heplisab-B, which is the new adjuvanted vaccine, with one of the current vaccines at different age groups and different risk factors. And clearly you can see the improved response in all of the age groups tested. The new vaccine led to antibody conversion in over 90% of all the recipients, unlike the current vaccine. So this is the advantage of the new vaccine, and the other advantage is the speed with which you get people immunized, and that's illustrated here in this graph, these 2 graphs of 2 different studies of adults, different age groups, but the top line is the percent of adults in these studies who were protected, reached a protective level of antibody, and the bottom line is using conventional vaccine, the top line is using the new vaccine. So more people are protected because more convert, and they're protected faster because you can get there just with 2 doses 1 month apart. So we may eventually see this vaccine recommended in children as it gets studied in younger populations. I think for certain populations it would be an advantage to only have to give 2 doses of hepatitis B vaccine. The other new vaccine I want to talk about is here to address this problem, that we have a disease that affects 1/3 of all adults. It's extremely painful. It can be debilitating for months in a subset of adults. It's a disease that we can prevent, and we're not doing a very good job of preventing it. And of course, I'm referring to shingles or zoster, which continues to be a big problem and increases in prevalence as age goes up. We do see shingles in children, but it's quite rare, as you know, and this new vaccine is not targeting children, but is another example of the use of adjuvants. So zoster is a worldwide problem, and as illustrated here, the older you are, the higher your rate of zoster is, and the higher your rate of post-zoster neuralgia, which is a debilitating neurologic condition that follows zoster in a subset of patients. So this new vaccine, which is the herpes zoster subunit vaccine, has the brand name of Shingrix, was just licensed by FDA in October of 2017, and then recommended for routine use by ACIP in October, also later in October of 2017. This is also a 2-dose vaccine, and unlike the current zoster vaccine, which is 1 dose, this one takes 2. But its immune response is clearly superior to the current zoster vaccine, and as a result, ACIP lowered the age for routine zoster vaccination to 50, and made a preferential statement that this new vaccine, the subunit vaccine, should be given preferentially over the live vaccine. So just to contrast the two viruses, Zostavax is the live vaccine, which we've used for a number of years. It cannot be used in people who have compromised immune systems. It was recommended starting at age 60, and it had an overall effectiveness of around 50%. The new vaccine is a recombinant vaccine, so it's not a live vaccine and therefore should be safer in immunocompromised patients. It contains a novel, different adjuvant than the one I discussed for hepatitis B vaccine. It does require 2 doses, but it works better, and therefore the CDC lowered the age to 50. And here's the vaccine effectiveness data that compares the new vaccine in the yellow bars with 2 different studies of the Zostavax live vaccine at different age groups, 50 to 59, 60 to 69, and over 70 years of age. So you can clearly see that the new vaccine outperforms the old vaccine, particularly in adults 70 years of age and above. And it not only prevents zoster, but it prevents post-herpetic neuralgia also much better than the old vaccine in adults 70 years of age and above. The other issue with the current, or the vaccine we've been using for a number of years, is that the immunity wanes over time. This is several different studies showing that waning immunity, so that somewhere between 5 and 10 years after you've received the old vaccine, your immunity has gone down and you may no longer be protected. So that was recognized just in the last couple of years. This is the data we have on the new vaccine, as shown at the top red line. That vaccine immunity looks like it also wanes, but perhaps more slowly than the previous vaccine, although we only have 4 years of data. So time will tell about that. But again, the important difference is you start off with a much higher percentage of people responding to the new vaccine. So why does this vaccine work better? Again, this has to do with adjuvants. We know a number of things about our immune system's response to vaccines. In general, live vaccines work better than inactivated ones, but that's not the case in this example. We know that proteins usually are better antigens than pure carbohydrates. We know that in the case of pertussis, the whole cell vaccine was actually better than the recombinant DTaP vaccine. We gave up on whole cell because of safety issues, but immunologically it was better. And then down below, I've listed a number of categories of adjuvants. Alum has been in many, many vaccines for decades, but the rest of these adjuvants are more recently developed and are the future of vaccines. You're going to start to see them incorporated into more and more vaccines. So this slide is one from the company that makes Shingrix, just listing for you on the right-hand side the 3 different adjuvant molecules, the MPL, the liposome, and the saponin molecules, which are all combined together with a recombinant antigen from the virus, and that's what makes up the vaccine. So again, it's not a live vaccine, it's an inactivated vaccine, but it has these adjuvants, or this adjuvant system in it, which induces much better immune response. So that's the good news. Here's the bad news about adjuvants. Adjuvants stimulate your immune system, so as a result, we tend to see more local reactions and sometimes even systemic reactions from the vaccine because of the vigorous stimulation of your immune system. So, for example, there's more arm tenderness or redness or swelling at the site of the injection. With some adjuvanted vaccines, there's an increased rate of fever or other systemic symptoms. And there is the theoretical concern about autoimmune reactions, although I want to emphasize that has not been seen yet with any of the adjuvanted vaccines or adjuvant systems that are in use, but it is a theoretical concern which is going to continue to be monitored. So here's a slide that illustrates this increased side effect profile of the new recombinant zoster vaccine. This is 2 different studies in the orange colored bars compared to a placebo group. And so you can see that more than half of the recipients had pain at the injection site. 30 to 40% had redness, 20 to 30% had some swelling. So you need to be aware of this. If you personally are going to get this vaccine, providers who take care of adults need to make sure their patients are aware of these increased side effects. And as we start to use these adjuvanted vaccines in children, we're going to need to be on the lookout for increased side effects. This next slide just summarizes some systemic effects, same phenomenon, more fatigue, more fever, headache, other generalized symptoms. So there is a downside to the adjuvanted vaccines, or at least some of them, that we're going to have to be aware of. So here's the recommendation. The new vaccine, as I've said, is recommended starting at the age of 50. It is recommended in people who have already had zoster, and it's also recommended for people who've already had the previous live vaccine, Zostavax. So regardless of your past history, you should be getting this vaccine. There are no recommendations as yet for use in immunocompromised patients, but because it's inactivated, that may be something that will be coming forward in the near future. It can be given with other vaccines at the same time, although patients need to be aware of the side effects, and particularly as we use more and more of these adjuvanted vaccines together. So, for example, we have an adjuvanted influenza vaccine that's relatively new on the market. I've talked about the adjuvanted hepatitis B vaccine, and now we have the adjuvanted zoster vaccine. So as we start giving all of these adjuvanted vaccines together, we may eventually reach a point where the cumulative side effects are going to indicate that we cannot give them all simultaneously, but time will tell on that. The last thing I want to cover before I open this up to any questions is a reminder of pertussis and how over the last decade or so we've seen the upswing in pertussis around the country. This graph shows our experience in California. It is looking like this current season is going to be another big season for us, and that would be typical or expected because pertussis tends to go in 3 to 5 year cycles in any one state or community. Our last outbreak in California was in 2014, so we're getting about ready to expect another one. And so far this season, we are seeing an increased number of cases this year compared to the last couple of years. So pertussis continues to be a problem, and I mentioned earlier that part of this issue has to do with our conversion from wholesale pertussis vaccine to the recombinant acellular vaccines. So the big issue for us is Tdap vaccine during pregnancy. That is, this is the only effective mechanism we have to prevent pertussis in young infants, and this clearly works. Here's data published in the last year from Northern California Kaiser showing a vaccine effectiveness over the short term of 90%. That is, you protect newborns from getting pertussis with a 90% effectiveness by immunizing pregnant women during pregnancy. As expected, that effectiveness drops off over time as the maternal antibody goes away, but even up to a year follow-up, there's a 69% vaccine effectiveness. So between that and immunizing infants as they age into their recommendation for DTaP vaccine, then we're going to do our best to prevent pertussis in young infants, which is the most vulnerable age group, as everybody knows. So we need to continue to emphasize pregnancy vaccination, and this is why this is data from last year from the MMWR showing how we're doing with use of Tdap vaccine during pregnancy, and we're only getting about 50% of pregnant women to get immunized. So as pediatricians, we need to continue to advocate, make sure expectant mothers who are in your practice know about this, and we need to work with our OB colleagues to make sure that we increase the rate of pertussis immunization, Tdap immunization during pregnancy. The safety has been pretty well established by now. There are no safety concerns with use of Tdap in pregnancy. And so it's clearly something that we need to promote. So in summary, I know I've covered a lot of territory, some of it not directly related to pediatrics. The biggest point, I think, for everyone to be aware of is that the live attenuated influenza vaccine is being reinstated in CDC recommendations for the coming flu season, so it will be available. Infants between 6 and 11 months of age should now get hepatitis A vaccine when they're traveling abroad. We need to keep increasing our efforts to get birth doses of hepatitis B given in the first 24 hours of life. We have these new adjuvanted vaccines currently recommended for adults, but I expect to see more use of adjuvanted vaccines in general in children, and perhaps the hepatitis B vaccine in particular. And please keep promoting Tdap during pregnancy to protect infants. That's all I wanted to cover, and we'll open this up for questions. And Anne, I'm not sure if you're going to read the questions or I'm supposed to be seeing them on my screen.
I'm going to be reading them, Dr. Sawyer. So let's go ahead and get the question and answer started then. I know that, just to remind everyone, it is going to be on that right-hand side control panel. So let's see. I am not seeing any at the moment right now, so I'm going to quickly go over a couple of the finishing up housekeeping items, and then, as people have those questions and they get ready to type them in, feel free to go ahead and do that. So we have one upcoming webinar that we have scheduled. That's going to be our business side of vaccines webinar. Is taking place on July 19th. That's a Thursday. And it'll be from 12 to 1 p.m., just like our usual webinars. We also have a couple in the pipeline that we just don't have a specific date yet, and that would be for meningitis, as well as a couple flu webinars once flu season gets started later on in the fall. And then, so what next for everyone? You'll all receive a copy of the PowerPoint slides, a link to complete the evaluation, and a link to the recording of the webinar by the end of business day tomorrow. You must complete the evaluation by May 11th, 2018. After this date, the evaluation will be closed and you will no longer be allowed to fill out the evaluation or receive a certificate of attendance and or continuing education credit. You will receive your certificate by May 25th, 2018. Oh, looks like I do have a couple questions right now. So the first one is, for healthcare professionals, is LAIV the less preferred form of flu vaccine for next season?
So ACIP, the CDC, is not making any preferential statement of one product over another. So it is an option for healthcare workers to get LAIV. It's not preferred or discouraged from CDC's point of view. The AAP perspective that I shared from the Committee on Infectious Disease is solely focused on children, and that's where the biggest concern is about possible lack of effectiveness, and we're waiting to get better data about whether the new vaccine has really regained its effectiveness.
Okay, and then another question that I have is, how long has the new vaccine for shingles been available?
So the new vaccine was just licensed in October of 2017. It is just now sort of getting available in physician offices. So I actually had my physical this week, and my physician has it now. Public health departments are starting to get it. Pharmacies also have it. So it should, by now, pretty much be available in most communities, at least in some settings.
Just to kind of add to that, my mom also just got it at Walgreens. So it's available everywhere, it seems like, at the moment for the new shingles vaccine. And then another question is, when is the best time to give Tdap to a pregnant mom? Is it third trimester? Can you give it for any trimester?
It's safe to give at any trimester. The emphasis is on the third trimester, though, and the reason for that is that gives us the biggest boost of antibody for the baby. Is to immunize women in the third trimester. You want to get them immunized before 36 weeks, though, because you want time for the mother to respond and transfer antibody to the baby. So current recommendation is the best optimal time is between 27 and 36 weeks of gestation. But it's okay to give at any time.
Okay. Oh, and then we have a follow-up question to the shingles vaccine. It's how do we have the knowledge on its effectiveness then?
So the effectiveness data that I showed you comes from clinical trials. They did pretty large clinical trials to show its effectiveness. Having said that, we often learn after a product gets out on the market and it's used literally in millions of people instead of thousands, that those numbers sometimes get refined. But based on the clinical trial data, it clearly looks to be better than the existing vaccine.
Okay, and then another question is, what is the spacing for the 2 doses of Shingrix vaccine?
So that vaccine is spaced, now I'm hesitating, it's either 1 or 2 months apart for those 2 doses. I think it's 2 months is the standard recommendation. Sorry, I'm blanking out on that because I'm getting the new hepatitis B and the new zoster vaccine confused. But it's 1 or 2 months, and you do need to get both doses in order to have the benefit of the improved immune response. So that's one important difference between the old vaccine, which was a single dose vaccine. This takes 2 doses.
Okay, so I'm not seeing any new questions right now, so I think we can safely go ahead and wrap up the webinar. So thank you. Oh, wait, I think I just had one pop up real quick. Oh, what is the recommended age for the shingles vaccine?
So the new shingles vaccine is recommended starting at age 50, and that's different than the old one, which was not recommended until 60. It's licensed for adults 18 and above, so it's not yet recommended for younger adults, but physicians may have some patients for whom they want to consider using it at even a younger age. But the CDC recommendation is to start at age 50.
Okay, great. I'm pretty sure this time that we have covered all the questions. So thank you so much, Dr. Sawyer. I think you gave us a lot of new information, especially about LAIV. And I think we all have a lot of, future questions about it, but we'll be sure to look out to see what the CDC and ACIP officially publishes. And thank you again also to everyone who attended this webinar, and we hope to see you again for our future webinars. I hope everyone has a great afternoon. Thanks, Dr. Sawyer.
Thank you.